Hey, welcome back to Not So Complicated, and today we are beginning a new case series, a clinical case discussion, day 1. And here is the case. Well, a 62-year-old male presents to the emergency department with a sudden onset of severe chest pain that began 1 hour ago while lifting a heavy box. He describes the pain as a sharp, tearing sensation starting in the anterior chest and radiating through to his upper back. The pain is unrelenting, rated 10 by 10, and he feels faint. Past medical history includes poorly controlled hypertension on no meds and a 30-pack years smoking history. He denies recent trauma beyond lifting. So basically the key points here are the male is 62-year-old, the pain is sudden and severe, and also the pain is sharp and tearing sensation restarting in the, so it's basically chest to upper back kind of pain. And the pain is rated 10 by 10, which means it is severe, and he has uncontrolled hypertension and a history of 30 pack year of smoking. Well, it kind of arrows us to the cardiovascular system. Let's see the what's an examination. The examination shows BP is 190 by 110 mmHg in the right arm, and BP is 150 by 190 mmHg in the left arm. So the blood pressure is unequal in both arms. It can be due to aortic stenosis or regurgitation, or maybe due to aortic dissection also. And the heart rate is 110 beats per minute, which is slightly raised. And the respiratory rate is 24 per minute, which is also raised. Oxygen saturation is average or moderate, 92% is in room air, and a physical exam reveals a soft diastolic murmur at the right sternal border. Okay, and a subtle difference in radial pulses, and ECG shows non-specific STT wave changes. So basically ECG is unreliable in this case. And what is the most likely diagnosis? So basically let's see the options. What are our options in here? The options are acute myocardial infarction, aortic dissection, pneumothorax, pulmonary embolism, esophageal rupture. We can directly go to the options, but let's do the elimination and then choose any option whether it is our answer or not. Let's debunk each of the options. Acute myocardial infarction. Well, the pain in MI is squeezing or crossing pain, and it is substernal, and it radiates to the left shoulder and left arm. Well, the case here has a sharp or tearing pain, which is unlike to the MI, and there is also no history of nausea or sweating dominance here. And there is unequal BPR pulses, which means it is a vascular case and not coronary case. And ECG is non-specific also, because myocardial infarction needs either ST elevation MI or ST depression, and there is a history of hypertension and smoking, which fits, but this is not a clogged artery, because all other symptoms doesn't match in here, so this is very highly unlikely to occur in this case. The next option is aortic dissection, which means the pain in aortic dissection is sudden or tearing pain, and it is also chest to back, which fits entirely to our case. And the unequal BP, almost 40 mmHg gap, pulse deficit, new murmur or aortic regurgitation. This is the dissection's calling card. Obviously the aortic dissection almost entirely matches the symptoms in here, and also hypertension is the risk, smoker is a bonus, and lifting triggered it. And ECG is non-specific because it's not the heart muscle, so this might be the answer. Let's hold it, but still we can go to the other options like this. The other option is pneumothorax. The pain in pneumothorax is sharp, especially if it is due to rib fracture, but pleuritic or unilateral and not tearing to the back. And there is no trauma beyond lifting, so no rib snap or rib fracture. There is no sudden O2 crash, or 92% is mild oxygen saturation for room air, and there is no tracheal shift or absent sounds. There is unequal pulses, and BP doesn't fit in here. Smoker is a red herring, so let's put it aside for now. The another option we have got is pulmonary embolism. Pulmonary embolism causes dyspnea, and this is the one most sign that is presented with dyspnea, and then pleuritic or dull pain, and it is not tearing or chest or back pain, and it also causes tachycardia, which is SR 110 fits, but there is no hypoxia drop. Oxygen saturation is again mild, and there is no deep brain thrombosis hints and no Wells scores. If there is no DVT, we can't possibly develop the Wells score, and there is an unequal BP or pulses, and murmur doesn't play. So pulmonary embolism is lung, not aorta. So this is also very unlikely to go into the Wells score. There are criteria, and each criteria is assigned some points. There are clinical signs or symptoms of DVT is assigned 3 points. PE is most likely diagnosis, 3 points. Tachycardia greater than 100 beats per minute is 1.5 points. Immobilization or surgery in previous 4 weeks, which we don't have any history of that in this case, is 1.5 points. Prior DVT or PE, no history, 1.5 points. Hemoptysis, there is no clinical symptom of hemoptysis, no active malignancy. So on calculating the points, low risk or intermediate risk and high risk, there is P unlikely, 0 to 4 points. P is very unlikely, and P is likely if there is greater than 4 points in the Wells score. So this cannot be the case in our presentation right here. So the debunking next slide, we have got esophageal rupture. So esophageal rupture is perhaps post-vomit. Perhaps vomiting is a forceful vomiting which causes retching. It is slightly different than Mallory West tear, but it's still due to the vomiting, retching, forceful vomiting. Perhaps post-vomit. Epigastric tearing, yes, this is present, but there is no retching and just lifting in here. There is no history of vomiting. There is no mediastinitis or fever or shock, no crepitus. Pain is too aortic because it is radiating from chest to back, and it is not from chest to gut. BP is also high, so it is not crashing. Esophagus is not rupture, so it is definitely out. So basically, seeing all these options and analyzing, we can develop the diagnosis as aortic dissection for sure. So what is an aortic dissection? Aortic dissection is an intimal tear in the aorta. Blood splits tunica media, which is the middle layer of blood vessel, and then false lumen is found. There are two types of aortic dissection. Stanford A, which is ascending and emergent, and Stanford B, which is descending and managed. So basically, this guy is A, Stanford A aortic dissection, because murmur is there, and slight diastolic murmur is there, which is due to aortic root, plus there is chest pain. So this case, in this case, 1 hour is in hypertension driven, lifting stress, ascending aorta is ruptured. Also, what can be the causes? Because the hypertension is a major cause. 70% of cases I have hypertension is history, and this also has uncontrolled hypertension plus smoking, which is vessel wear, and this causes intimal tear. Lifting, spiked blood pressure, tore it open, and false lumen grew, and the result is that the pain, tearing, migrating, false lumen compresses through, and unequal pulses of BP, aortic regurgitation, murmur from root involvement is there, and the time is 1 hour, which is survivable for now, but 50% is dead in 48 hours without surgery. And the signs are unequal BP or pulses greater than 20 or 40 mmHg normally, and there should be new murmur or regurgitation. There should be widened mediastinum in chest exteriority, which cannot be seen directly. And imaging, we have to do CT angiography, which is gold standard to show false lumen, and TEE, which is transesophageal echocardiography if it is first, and MRI if the patient is stable. And ECG is non-specific, which rules out MI, and also ECG doesn't show widened mediastinum, so we have to do chest X-ray or CT. This guy is, we have to do CT stat, BP gap, murmur, pain, dissection till proven otherwise. troponins are negative, chest X-ray should be done next, and we have to manage this patient. If the patient is in acute case, beta blockers, esmolol, to bring heart rate and blood pressure down, and nitroprusside to control systolic blood pressure to 100 to 120, and to control pain, to relieve pain, we have to give morphine. And if the patient is stand for A, surgery start, replace ascending aorta, 10 to 20% of mortality is there in the surgery. And if the patient is stand for B, we have to do medical management on less complications. And in this case, we have to do OR now. OR means suppression room right now, and STN is killing him. Murmur is the red flag. What is the prognosis? Prognosis is the risks are rupture, which is pericardium, rupture pericardium, and death, and the stroke, organ ischemia, which are due to hypertension of all odds. And the stats untreated 1% per hour mortality in first 24 hours and 50% is dead in 2 days. But if we have done surgery, it drops the risk of mortality to 20%, 10 to 20%. That is it. And subscribe for our next case discussion. Thank you.